Doctors have been saying the same thing for 40 years. Once plaque builds up in your arteries, it's there. You take your medication, you try to slow it down, you try to stop it getting worse, but you don't reverse it. That's still the standard position. That's what most cardiologists say in the consultation room today. And here's the thing. In the last 2 decades, actual peer-reviewed studies have shown something that quietly contradicts that. Not a wellness blog, not a supplement company funding its own research, peer-reviewed journals, and 2 of the most surprising findings. One comes from a pomegranate, the other from a fermented Japanese soybean. I'm going to walk you through the actual studies, the numbers, what the researchers found, where the evidence is solid, and where it's not. 3 questions I want you to hold on to as we go. What do drugs actually do to plaque, and how much? What did these food studies actually find? And what are their real limits? And why do 2 completely different compounds seem to hit the same target? Let's go. Before the studies, I need a couple of minutes of background, and I know that sounds like the boring part. It's not, because once you understand how plaque actually forms, the rest of this video makes a different kind of sense. Most people think it's basically fat in your blood, fat on your artery walls, pipe gets blocked. That's not really how it works. So your artery has this inner lining. It's called the endothelium. And, over years, that lining gets damaged. High blood pressure, inflammation, smoking, oxidative stress, just wear and tear basically. And where it's damaged, you get a weak point. LDL cholesterol works its way into that area. But here's the thing. LDL sitting in your artery wall isn't actually the problem. What happens next is the problem. That LDL gets oxidized. It reacts with free radicals and turns into this toxic inflammatory version of itself. Oxidized LDL. That is, the match that lights the fire. Your immune system sends in these cleanup cells, macrophages, to deal with it. And they try, but there's just so much of it over so many years that they get overwhelmed. They fill up with cholesterol, and they die. Researchers call those foam cells a cluster of foam cells hardened with calcium deposits held together by a protein scaffold called fibrin. That is a plaque. Think of it like a bath with the tap running. You can work on draining it. And we're going to talk about some things that seem to do exactly that. But if the tap's still on, you're always fighting the level. We'll come back to that. The 2 compounds I want to show you don't work by lowering your LDL number. Statins do that. These work on different steps entirely. One targets the oxidation of LDL, the match. The other targets the fibrin scaffold, the structure the plaque builds itself on. That's why the data is interesting. All right, statins first. Because if I skip this or soft pedal it, the rest of the video doesn't hold up. High-intensity statins are genuinely powerful. They can cut LDL by 50 to 60%. That's a real number. In the asteroid trial in 2006, researchers put patients on high-dose rosatin and drove their LDL down to an average of 61 milligrams per deciliter. Most cardiologists are happy if you get below 100. These patients were at 61, and for the first time in a major trial, they saw actual measurable regression, plaque shrinkage on all 3 imaging measures they were tracking. That was a genuinely significant finding. But here's the part the headlines didn't really report on. The regression was real, and it was tiny. Less than 1% decrease in plaque volume. Statistically significant, clinically meaningful over time, but the car moved backwards barely. It's nowhere near the garage. Then, in 2016, the GLAGV trial pushed further, added a PCSK9 inhibitor on top of statins, drove LDL down to around 36, historically low, and 64% of patients showed regression. More impressive. But now you're talking about 2 drugs combined driving LDL to levels essentially nobody achieves naturally with medical supervision the whole time. And still, the absolute changes are modest. So that's where drugs stand. Real proven, but limited. And researchers started asking, is there something else going on here that we're not looking at? In 2004, a researcher named Professor Michael Averam at the Rambam Medical Center in Israel published a study in clinical nutrition that barely anyone outside research circles talked about. He recruited 10 patients already diagnosed with carotid artery stenosis. Confirmed plaque confirmed narrowing in the arteries of the neck, not healthy volunteers. People with a real documented problem. He gave them pomegranate juice every day for a year, 50 to 60 milliliters, less than A4 cup, concentrated 100% juice, no added sugar. When I read these numbers, I went back and checked the paper twice. Turporn destastintier dodiciae. Control group, patients who didn't take the juice, their carotid wall thickness increased by 9% over the year. That's normal disease progression. That's what happens when you change nothing. The pomegranate group, their IMT carotid in time of media thickness reduced by 35% at the 12-month mark, confirmed by ultrasound, and it was consistent 13% at 3 months, 22 at 6, 26 at 9, 35 at 12. Not a blip, a trend. And then they measured LDL oxidation. It dropped by 90%. 90. And here's the thing that makes this interesting. Total LDL cholesterol didn't change. The juice wasn't lowering LDL numbers. It was making the LDL that was already there far less likely to oxidize. Remember the match that lights the fire? That's what it was going after. Pomegranates have this unusually high concentration of polyphenols, among the most potent antioxidants found in any food. They seem to reduce oxidative stress directly in the arterial wall. And there's some evidence they help HDL, pull cholesterol back out of existing plaques. That's called reverse cholesterol transport, a mechanism for actual shrinkage, not just stabilization. Now, I have to be straight with you because this is the part most videos skip. 10 patients, no randomization. You can't build a treatment recommendation on that, regardless of how striking the numbers are. In 2009, a much larger trial, the Davidson study, gave 240 milliliters of pomegranate juice daily to 249 participants for 18 months. Randomized, controlled, and in the overall population, no significant difference in carotid IMT progression. So the bigger trial didn't replicate it. But when they broke it down by subgroups, people with the highest oxidative stress markers at baseline did show benefit, which actually tracks with the mechanism. If your LDL oxidation is already very high, reducing it by 90% matters a lot more than if your oxidation was already low. Honest summary: one striking trial, one larger trial that didn't replicate in the general population, but found something in the high-risk group. Promising, not proven for everyone. If you have high oxidative stress, your doctor can test for that. It may be worth exploring. The downside is basically nothing if you're watching sugar. Now, the second compound, almost nobody in the Western world has heard of this, and when you see the study numbers, you'll understand why researchers are paying attention. Nattokinase is an enzyme produced during the fermentation of soybeans. The Japanese have been eating fermented soybeans, natto, for over 1,000 years. There's a long-standing correlation between natto consumption and lower cardiovascular disease in those regions. Interesting, but correlation isn't the same as causation. So researchers isolated the enzyme and tested it directly. In 2022, a clinical study in Frontiers in Cardiovascular Medicine looked at 1,062 participants, the largest human study on nattokinase and atherosclerosis done to date. All had confirmed atherosclerosis and elevated lipid levels. They were given nattoaz at 10,800 fibrinolytic units per day for 12 months. That's the standardized unit for enzyme activity. After 12 months, carotid plaque area reduced by 36%. Carotid IMT down 21.7%. LDL fell. Triglycerides fell. No adverse effects recorded at this dose across over 1,000 participants. How does it work? Remember the fibrin scaffold, the protein structure that plaque builds itself on and hardens within. Nattokinase is a fibrinolytic enzyme. Its specific job is to break down fibrin. By degrading that scaffold, it may make it easier for the body to reabsorb the cholesterol deposits trapped inside the plaque. It also seems to inhibit platelet aggregation and has some direct antioxidant effects on LDL. Completely different mechanism from pomegranate. Different entry point into the same process. Now, the limitation, and I want to be direct about this because it matters. This was an observational study, not a randomized controlled trial. There's a meaningful difference. The researchers themselves call for randomized trials to confirm it, and there's a second trial you need to know about. 20,000 South on E2 in 2001. USC's KEK, School of Medicine, the NAPS trial. Randomized, controlled, 3 years, 265 healthy adults. NATO at 2,000 fibrinolytic units per day, 0 effect. Walk into any supplement store right now and ask for natokinese. You're going to walk out with 2,000 units, the exact dose that showed 0 effect over 3 years in a randomized trial. The Chen study used 10,800 units, more than 5 times higher, and within the Chen data, lower doses produced significantly less effect. The dose-response curve is steep. Below a certain threshold, there just isn't enough enzyme present to do anything measurable. That gap between what the research actually tested and what's on the shelf, I find that genuinely frustrating. Nobody is talking about that loudly enough. So, we've got statins working on LDL levels, pomegranate working on LDL oxidation, natokinase working on the fibrin scaffold, 3 different entry points into the same disease process. But there's a body of evidence that answers a different question. Not how do you work on plaque that's already there, but can you actually remove the conditions that create it? Dr. Dean Ornish, cardiologist at UC San Francisco, ran a randomized controlled trial testing a comprehensive lifestyle change. Very low-fat plant-based diet, aerobic exercise every day, stress management, smoking cessation, no drugs, no supplements, just changing how people lived. After 1 year, the lifestyle group showed a 5.5% reduction in coronary artery stenosis. The control group, people on standard medical care, worsened by 5%. After 5 years, the lifestyle group kept improving. The control group kept declining. In 2010, the direct carotid trial showed a 5% regression in carotid vessel wall volume across diet groups independent of which specific diet they were following. Remember the bath with the tap running. Statins help drain it. Pomegranate helps drain it. Natokinase helps drain it. But if the tap, the chronic inflammation, the oxidized fats, the metabolic dysfunction, if that's still running full, everything else is working against a rising tide. Lifestyle is what turns the tap off. And when the tap slows down, everything else works better. These aren't competing approaches. They're working on the same mechanism from different angles. All right, where does this leave you practically? Best supported approach we have, aggressive LDL lowering with statins, especially below 70, combined with serious lifestyle change, multiple randomized controlled trials, decades of follow-up data. That's the foundation. Pomegranate juice. 50 to 60 milliliters of concentrated juice, daily striking in one trial, mixed in the larger RCT. Benefit seems concentrated in people with high oxidative stress mechanism, is real risk. Is basically nothing worth adding. If you have a solid foundation, already don't treat it as the foundation. High doses natokinase, and I mean 10 to 800 units, not the 2 on every shelf. The observational data is the most dramatic we've seen, hasn't been confirmed in a randomized trial at that dose. Yet if you explore natokinase, tell your doctor first, especially if you're on any blood thinner, antiplatelet, or aspirin. There's real fibrinolytic activity here that can interact with those. And here's what to actually say to your doctor. Ask to have your oxidized LDL tested. Ask what your target LDL actually is. Not just whether it's normal, but what number are we aiming for and why? Show them the Chen-Natokin study and the Avaram pomegranate study. Ask whether there's a structured lifestyle intervention they can refer you into. Those are specific questions. They shift the conversation away from managing the situation and toward what's the direction of travel here and what can we do to change it. The idea that plaque is irreversible, that once it's there, you're just managing a slow decline. That's not what the evidence says. It hasn't been for a long time. The car can move backwards. That's been shown in randomized controlled trials measured with ultrasound published in peer-reviewed journals. The car can move backwards. What we don't fully know yet is how far. for whom, and with which combination of approaches. But that's not a reason for cynicism. That's the map for where the next 20 years of research is going. The changes aren't dramatic. This isn't 6 months of pomegranate juice and 20-year-old arteries. But the direction can change. And in a disease where the wrong direction kills you, that matters. Every study cited has a PubMed link in the description. Show your doctor. Have the conversation. If you know someone who feels like the story is already written, send them this. The research says otherwise.